Good afternoon or evening and welcome. Kensington Senior Living has 8 unique communities, 5 located in Virginia, Maryland, and New York, and 3 sister communities located in California. Kensington is truly working, sorry about that. Kensington is truly privileged to support our care partners and professionals from coast to coast. We focus on relationship-based care, care built on the foundation of our promise to love and care for your family as we do our own. It is programs such as the one you are attending now that are so important for those of us walking through a caregiving journey to hear from expert professionals on keeping us current with the latest advances in care, management, and treatment of conditions that affect seniors and their families. I was first introduced to Kensington over 10 years ago as my father was a resident there for over 7 years in Northern California. Everyone that registered for today's event will receive a copy of the webinar to share with friends and family. Please also utilize the Q&A function to submit questions for our panel. Today is for you. Please use the opportunity to ask questions. The part 2 of the series will be March 5th at 3 p.m. Pacific time. Your registration for today will be the same for part 2. Please join me in welcoming Dr. Ayati, a friend of the Kensington in Northern California and the medical director. I have had the pleasure of producing educational events with Dr. Ayati for years, and his knowledge continues to impress me. Thank you for joining us, and please share with the audience a few words about yourself. And to everyone in the audience, you are in for a treat today. Thank you, Dr. Ayati. And as a reminder, a copy of the webinar will be sent to everyone that registered. Please share with friends, family, and other professionals in the senior living space. Thanks for joining us. You can take it away.
Thank you so much, Susan. I appreciate it for a warm introduction as well. And it's a pleasure to be here. I'm so happy to be at another educational events with Kensington. And thank you so much for coordinating that. I think it's just believe that providing more education related, anything related, especially with neurodegenerative disease, is extremely essential for entire us. We are always learning. I'm personally learn every single day from my patients and from the evidence. I'm a geriatrician. I'm practicing in Northern California, and it's my pleasure to also be a privilege to be also medical director for Kensington Redwood City. I'm also adjunct associate professor of Stanford School of Medicine while where I'm actually teaching medicine, general medicine, and also geriatric medicine to our fellowship program as well. Um, Sorry about a little bit. My voice is husky. We're just sharing. I'm just recovering from post-influenza. If in the middle of presentation I cough or my voice is changed and I have to drink some water, please accept my apology for that. Without any reservation, I'm going to start. I'm going to share my screen and um, hopefully we can start to let me just go back here. Point of screen, let me see that. Um, just a second, what I think there is here we go. Some technical issues, okay. Okay, let me share again. Okay, perfect. Um, Let me do slideshows on. Okay, perfect. Are you seeing the slide as well right now?
Yes, we are.
Okay, wonderful. Thank you so much. It's my new laptop. I have some technical issue. Okay, discussion is about mild cognitive insufficiency, MCI, which we all aware of that, and we actually in the clinical practice these days, given the aging populations in entire world, including United States, many of elderly people are being seen and we see them with MCI diagnosis. The agenda that we're going to talk today is including the topics about understanding the MCI, mild cognitive insufficiency. But one of the things that I wanted to emphasize today, it's mainly going to have a discussion related to what is the normal aging brain. And that's something that I really wanted to focus on that because many time for many of us in clinical practice, many of our patients when they come, or we are as a primary care patients, we see the patients coming to us for years, and we see they're aging as well. And sometimes they may be forgetful, and there's going to be questions about is it just the aging brain or is the beginning of MCI? Why it is important, because then if you have MCI, we can talk about risk factor, we can talk about causes, we can talk about diagnosis, management, and the treatment that is available. Um, as we age, we all knowing that the brain goes through a lot of changes, and this is why I really wanted to emphasize the beginning that what is the difference between normal aging and what is the difference between the MCI, and I just have a brief conversation about that, and we can go more details about that. As you know, the normal aging, the first thing that happened to all of us, which is it started happening after the age of 30, not started at the age of 65. I'm always making this comment that the retirement age for brain is after age of 29, 30. Then brain decided to kind of like slow down and go toward more aging process. But still, we have neuroplasticity. Still, we have a brain that keep remodeling. I've always we know that by physiology that expansion of the brain that's happened till especially in the gray section till age of 28, 29. And after that age, whatever happened to us, it's mainly remodeling. We are making it much better. We're changing the cabinet, we're changing the tile, we're changing the curtains, we're changing the color of the wall. And for example, with anything that we learn, anything that we do, and this is going to be more what we talk discussion about neuroplasticity, exercise, learning the new things, and be active with the brain. But structural wise, it's not going to expand more, which we know every decades of our life, we're starting to have shrinkage. I'm not going to go toward more details on that, but one of the things that we know that by aging, it's normal to have slower information processing. We call speed of or processing the speed. We're going to be much slower. And we can easily see in ourselves, for example, when we turn from 40 to 50, 50 to 60, we're not going to be as fast as multitask as before. And occasional forgetfulness may happen with aging. It's generally mild and is not concerning. Unlike the MCI that we are discussing today, the normal cognition that happened with aging is not going to be disrupted life, the daily active life. Like, for example, you are still able to manage your work, you're still able to practice as a physician, you still practice as a nurse or any the jobs that you have, but you may gonna have sometime episodic, you may not remember the names, you may not remember the some stuff, but it's not going to have effects on normal aging on a daily basis. As we discuss, as we getting older, the brain is start to shrinkage, and this is a structural change that is happening, especially in certain area. These changes are often part of the aging. If you have your own MRI at the age of 30, and then you have your MRI of the brain at 40, and you have it on 50, and you have it on 60, you can easily see that the size of the brain is start to do the shrinkage. But it's not necessarily that's affect your cognitive. Your cognitive is still going to be okay, and despite of the aging. And the biggest question always we have the why this has happened, why we have this shrinkage that happened to the brain, and this is exactly what we know as in the science called apoptosis. Apoptosis is actually program death of the cells. And we know that it's a lot of the biomedical events, a lot of enzymes that happen that actually cell have just a specific lifetime, and then they're going to die. Um, we know that, for example, in the kids at the age of 8 to 14 years old, they lose 20 to 30 billions of neurons a day. And adults, they lose like 50 to 70 billions of neurons a day. But we still have a factory or manufacturer still producing it. And for example, if you lose 50 billions of neurons today by midnight tonight, we're able to produce the same 50 billions or even more by tomorrow. The problem is that when amount of that we lose is going to be much higher that we produce the next day or same day. And that's going to be exactly the issue that we see the shrinkage is getting worse. Or like a people with Alzheimer's disease that we discuss, that lose is much higher than what we produce. And this is the most important things that we should understand. We always, as a daily basis, we are in the birthday and funeral. We always having new cells all around our body, not only neurons, skin, GI, you know that, kidneys, and we continuously having birthday of new cells. But at the same time, every single day we have funeral of our cells. That we are as a daily basis. We born and we die. We're born and we die. And I always like this analogy to reminding me that this is the way that we're expecting the life. And then the time when we have much more dead cells rather than birthday or the new cells or newborn cells, then this is the time that we're getting close to the dying situation. And as we know, this is a theory of aging. This is a theory of dying. And as we see that brain start to shrink, atrophy as we're getting older, as we discuss in that the gray section has started around like late 20s, and more in the area that develop last. Like whatever comes later, we actually first losing it. Whatever come late, it goes first. And that's true even for people with like a dementia. As you know, as you see in many of your patients with the dementia, when they're starting to losing name, they're first losing the name of grandchildren. They're still able to remember the children because grandchildren came later. And then will be children. And there will be the partner. And the later of the life, they only talk about their parents. They always talk about their mom, dad. Even the parents probably they identify as the partner identifies as the parents. The other things that happen with aging brain is the 5 to 20% of the blood flow loss. And that's very important, especially for many of us. It's important to understand about, as a primary care physician, that how much important to talk about the vascular, especially blood pressure and many other things that we need to have the better conversation about that because that's really going to affect that. When we talk about apoptosis of neurons, the silent cell death, which is a vital role is actually in maintaining the brain health because we have to get rid of the damaged cells. It's a very essential process for better development, better function of our brain. However, what happened is, as I discussed, excessive neural apoptosis cause the neurodegenerative disease, including Alzheimer, including Parkinson, including all group of alpha-synuclein disease, vascular, any other thing. And the majority of research is trying to uncover the mechanism behind this apoptosis and see the potential therapeutic strategies to protect neurons from unnecessary dead cells. As we discuss an individual, the speed of the neuron process tends to decline. As we're getting a slower processing speed, it can happen in everyday task. For example, or reaction time can be longer. Um, um, Even, for example, if you wanted to learn new tools, like when we see our kids, I can easily see, for example, in my son, when he was 5 years old, he was easier to figure out the iPhone, my iPhone. and able to play and navigate in iPhone. When I compare to myself, that it took for me like days to really figure out with all the apps and function and everything. And you can see easily that the brain is very different. And but I was not like this. I was much faster when I was in my 20s. But since I turned to my 50s, I can easily see myself that I'm much slower than before. I'm always making a joke about it when I was working as like a hospitalist, for example. I was able to do like lots of admissions, go to the emergency room, taking care of ICU at night. I was in like a rural hospital to ICU, and everything is actually on the hospitalist. And I was taking care of all of them. I was able to walk on the stairs, go up and down easily, and having like 12, 14-hour shift. But at this age, I really cannot do that anymore. I know that my synaptic plasticity has been decreased, and my ability to adapt and learn is getting less. It's not gone, but is less. And this is important to understand. This is exactly what we discuss with many of your patients when we talk about engaging in cognitive activities, engaging in brain health. This is exactly helping to reduce these effects, which can happen by aging. And this is come that. Then technically by age, we have more issues on frontal lobe, definitely executive function, working memory, attention, planning, organizing, impulse control, going to be much more affect that. And we know that as the people, like for example, getting MCI dementia is getting worse. I'm always making this analogy. Majority of my consult is close to the holiday time when the kids wanted to come see the parents, and they said, you know what, my mom always able to do a great Thanksgiving dinner, and she was great. She was planning 20, 30 people, recipes, putting all the plates, everything's ready. But this year, she was completely distracted. And this is kind of red flag, and the children's noticing that, and then they come and then they discuss about what's going on. And we talk about processing speed, the rate of the brain in and reading, math, listening skill, and again, may take longer to remember names and words. Less multitasking as we're getting older. It's so hard to be multitasking. I personally myself, if I writing a note of my patients and somebody call, I used to be able to answer the call, what I'm dictating, what I'm writing the note, what I'm checking the chart, but I can't do it anymore. And I can see easily that multitasking is getting much harder. I just need to focus. And like, for example, even if there is a background noise, for example, if the TV is on or if you're in the very noisy environment, it's just much harder to focus. And the focus is going to be harder. For example, if you ask them to have a questions, they're just going to be much harder. Now, all I said about that so far, it's about to understanding what is normal aging, which we know that there is some degree of memory loss, and but is not going to be interfere with your daily active life. And the most important thing is that, okay, if I have a patient, is it normal aging or is it MCI? And MCI can interfere with some daily activities. That's very important to know that. Why this is important? Because the progressing of MCI, it's important to understand, excuse me, that can go to actually severe decline of dementia. As you see in this picture, for example, somebody normal aging goes to the mild cognitive impairment and then dementia. And what we're looking at independent function in daily active living. And daily active living, it's mainly instrumental daily active living. For example, paying bills, take care of the bank account, able to take the medications independently. That's important. Like for example, if you see someone that get the bottles, like I have a blood pressure medication, losartan, and amlodipine, cholesterol medications, and the bottles are in front. Okay, well, should I take losartan once a day, twice a day? You see this, they forget that, they get overwhelmed, confused. That's not normal with aging. That's not normal with aging. Like you can be 85 years old and is still able to know, yes, I need to take my losartan once a day. I can read a bottle, I need to take it once a day. But when you see that instrumental daily active living, like for example, taking care of the bills. That's one of the biggest red flag. Then you see your patients or family member says, "Oh, we noticed the parents is not paying the bills. There's two, three bills have been missed in the mail or forgot to pay, um, writing the check incorrect. The pills, it seems that is not being taken." These are red flag for you that this is beyond of normal aging. That's why it is so important to understand it's mainly about a task, which is going to be more memory or thinking problems than other people in their age. um, is still able to perform normal daily active living. Like, for example, they are completely independent on toileting, dressing, they're able to feed themselves, they're able to go to take a shower, but they have a little bit more problem than as a daily living. Like, for example, driving, I'm going to talk about it, or having a little bit bump when they do the driving, or as I said, the paying the bills. But it's not severe that you think they have dementia. And 10 to 15%, all we know, the MCI people can develop dementia. I believe the diagnosis of MCI is one of the arts of and skills in the world of the primary care. Means that if you are, as a primary care physician, able to diagnose MCI and distinguish it from the normal aging brain, this is a wonderful thing that you can do, because then you can talk about risk, you can talk about plan, you can talk about management, and you can talk about many other things that is important to discuss about it. The type of MCI, as we know, we have two types of MCI. We have amnestic MCI, which is mainly memory impairment. The amnestic MCI primarily affects the memory. And excuse me, a non-amnestic MCI, it's mainly affected other skills of the cognitive function. For example, language, visual spatial skills. I'm going to talk about it a little bit. Executive function. It's a little bit different. Technically, you may have memory loss, but you will see that it's more in other domain of the brain, which is going to be non-amnestic MCI. When we talk about amnestic MCI, mainly, the main domain is just a short-term memory. Um, for example, they forget the recent events, what happened last weekend, what was the last conversation I had with you, difficulty learning the new information, especially, for example, if there's new tools, something, and they repeat the question. These are the mainly memory. And this type, which we call amnestic MCI, it's beginning of Alzheimer's disease. In mainly progress, as I said, 10 to 15% a year toward Alzheimer's disease. Non-amnestic MCI, which is non-memory domain, it's mainly going to be talking about executive function, language, attention, and visual spatial. More problem with planning, more problem with organizing, as I explained to you, more problem with navigating, more problem with language, word finding. When, for example, you have the conversation, okay? For example, when you do MOCA test and you say, tell me 11 words that start with letter S or F, or you tell me the name of animals, okay? These are the things that you can see the word finding. Attention deficits. Attention is very important. Focusing. For example, you ask a question and they easily go to the different direction, or they're not paying attention to what you told them. For example, hey, go to water the backyard, and they're not able to focus. And this type of the MCI, it's mainly going to different category: vascular, frontotemporal, and Lewy body. This is why the MCI can be in two category: amnestic and non-amnestic. And that's important, because when you are, as a primary care, you know that what are the domain that they have, then you can talk about a possibility of the dementia, the type of dementia that they may have. As epidemiology, I know that, of course, age is one of the major risk factor. You see that as the age of 60, 64, 65, 69, just going up. Of course, that age of 80 to 84%, we have like 25% with age coming on. The risk factor for MCI, of course, the people with the higher education, they either have a delayed MCI, which is going to happen, but later, but definitely lower education is one. But the most important thing is the vascular risk. I can tell you that since 2021, since pandemic, excuse me, how much it's coming about vascular risk, hypertension, CHF, obesity, midlife diabetes, stroke or heart disease. It seems that heart is really a main connector to the what we see as the vascular changes in the brain and then the MCI. People they have like atrial fibrillation, especially I've been so focus and really looking at evidence about association between atrial fibrillation and MCI. And it's amazing that, for example, people get atrial fibrillation at the age of 50 or 60, how they develop toward MCI. And of course, the ApoE4 genotype is one of the other risks. And the other things is the neuropsych symptoms. Like, for example, people with more behavioral symptoms, it seems that there's a kind of risk factor. A lot of the scientists are agree either it's the beginning of the symptoms of MCI, which I'm going to talk about it, or they can lead the brain toward the MCI. And one of the things is the pathology of the MCI, which is the MCI. It's a early clinical stage of neurodegenerative disease. And when we look at the autopsy of the people with amnestic MCI, we look at the Alzheimer's disease pathology, which, for example, we see tau, as you know, the tau tangles in the especially medial temporal lobes. Like people with MCI amnestic, when they died, we see the tau deposition. And we know the tau deposition usually has amyloid plaque decades prior to that. And then we have a tau tangles later, especially in the temporal lobe, medial temporal lobe. And that's exactly what we know. This is what I'm saying, that it is important as a primary care physician to diagnose MCI because you can open up the new conversation, what's going on, and help to educate the people to understand that. And we know that, for example, Lewy body disease or cerebrovascular disease, but mainly vascular, are more common in MCI than normal control. And we know that. Usually what we see Alzheimer's disease pathology, as I said, amyloid or tau, and mixed pathology also, it can be in long-lasting MCI, which can be mix of the vascular or Alzheimer and or those who die without progressing to dementia. And cholinergic study is very interesting because research on cholinergic markers challenges the hypothesis that cholinergic dysfunction drives early cognitive decline in Alzheimer's disease. As you know, many of the medication, like for example, you use like cholinesterase inhibitor is about cholinergic decline. This is the way that they found medication like donepezil, rivastigmine. They did autopsy of the brain of people with Alzheimer's and say, oh, the amount of choline is so low. That's why they made cholinesterase inhibitor. And that's why it's so challenging. Is it the people with MCI, they have really a choline deficiency? It's kind of like the challenge that this is really not the hypothesis for that. This is why I'm going to tell a little bit in further that using of the cholinesterase inhibitor has not been showing the really benefit of people with MCI as well. And that's very interesting. No, the symptoms is so interesting because a lot of people would think about MCI is only about memory. No, it's memory and behavioral symptoms. And I just really want to focus on mood and behavioral symptoms. I want to say that majority of the people that I was able to diagnose them with MCI, they actually presented to me with the behavioral symptoms. And then when we made, and it was very interesting, like for example, they brought the parents because, oh my God, my dad is so anxious or depressed. And when we do the screening test for memory, then we notice, oh, interesting, the memory is actually there. Or we refer them to neuropsychologists, and they're going to say, yeah, there is a component of cognitive decline in the picture of the depression. But depression is 25 to 40%, and irritability, anxiety, aggression, or apathy. Behavioral symptoms actually linked to more cognitive impairment. And it's very interesting that depression and cognitive decline we have the complex relationship. We know you know about pseudodementia, which is a part of the behavioral symptoms that can present with memory loss. But this can be early sign of cognitive impairment, and a study suggests depression should be could be early manifestation of decline, an independent risk factor for MCI or progression to dementia. And as the clinical implications, we know that mood and behavioral changes in memory complain, higher dementia risk, and close follow-up is recommended. But that's why I just want to say, if you want to learn one thing today, it's so important to just learn that yes, the behavioral can be early symptoms of the MCI. And when we talk about the memory loss, we're talking about amnestic type, which is mainly change from the baseline. And and for example, if the predictive value, for example, subjective memory complaint can predict the cognitive decline. Even objective tests are normal, but that subjective is important. Like sometimes you have someone that say, I have a memory loss, and then you do the testing, and it's not bad the testing, but that complaint, it's very predicted. I mean, you can predict easily the cognitive decline in the future, and that's so important to say that. But again, we just say that's part of the memory can be part of the aging. Influencing factor, as I said, mood, sleep, pain, of course, that can affect the memory as well. Some individuals meeting MCI criteria deny memory problems. And that's very interesting because a lot of time you have the people say, oh, I have no memory problem, but they have a lot of criteria that it goes to the MCI. And awareness and progression, unlike Alzheimer's disease, MCI patients are often troubled by symptoms. Over time, those converting to Alzheimer show more informant reported symptoms than self-reported and useful for tracking progression. And as you know, probably, for example, when you do the testing, a part of the testing you do like a visual spatial testing, especially for the people on non-amnestic MCI. You ask them to draw a clock, show me 10 past 9 or 10 to 11. And look, you see that the way that putting all the numbers, the way the circle is there, and all this stuff, it's really going to affect them with the testing and all this stuff. And one of the things in visual spatial skills, especially non-amnestic MCI, I always ask them, the family member, please take a photo of the driver's side of the car and show it to me. And you can easily see the number of the dent or any a problem there, especially when they're parking. Or you can easily diagnose a lot of MCI patients when you're just walking the parking lot, the way they're parking in the parallel parking. And that's one of the things that you can see about the visual spatial skills. I wanted to be a little bit faster that we can actually cover that. Now, diagnostic criteria, it's evidence of cognitive decline, preservations of independent in daily activity. That's so important. Means they're still able to do that. Is absence of dementia. They don't have dementia, but they have some problems that is doing it. This is why it is important to understand, are they able to do all the tasks independently? And that's very, very important to really kind of like a criteria for that. The key discussions is going to be really about financial, current events, activity of daily living, because that's really going to be something you knew that. You do the cognitive assessment usually in your office. You do valid tests like MMSE, MoCA test, which is a Montreal cognitive test, or other essential components. You do comprehensive medical and neurological exam. Why the medical exam? Because you may going to find your patient's mouth when you examine it or the breathing, the patient has a sleep apnea. You may going to do a cardiac exam and you find, oh, interesting, the patient has atrial fibrillation and they're not aware of that. You find irregular rhythm in your physical examination. You can find many cardiac situations that contribute to vascular. You can find high blood pressure. The patient has no idea about that. You can review the medications. If your patient's taking a sleeping medication, patient taking lorazepam every night, patient's taking non-benzodiazepine receptor agonists like an Ambien every night, and many other medication that can increase the risk. This is your time that with medications review, talk about MCI and risk factors. The sleep history, as we discussed, and a screen for psychiatry condition. This is the time that you get their form of the PHQ-9 or geriatric depression scale and say, this is the time we're going to go and do that. There's a lot of screening tests. I just brought it up, this Roland University from Australia. This is one of the simple memory tests that you can do. Is a 30 score. It's for people they're very kind of like stressed in the clinic, and you want to do mocha tests, and it's so hard for them to do all the tasks. It's so simple. It has visual spatial orientation. It's going to tell you that, for example, yeah, tell me where is your right hand, where is your left hand. With your right hand, show me my right, point toward my right elbow or my left knee. And then is a praxis part, which is you do the test. You ask them to copy the cube, which is a visual spatial construction. You ask the judgment. You ask them, for example, imagine that you are standing on a busy street. There's no pedestrian crossing. There's no traffic light. Tell me how you're going to cross this street. And then you give them four items, which is in this situation. There was a lot of discussion because in like mocha, you have face velvet church daisy red, or you have hand nylon carrot park and yellow. Oh my God, I'm able to remember that. Sometimes I forget the items, but there's different version of that. Excuse me. And then, and this one is so simple. You have grocery items. Excuse me. You have tea, cooking oil, eggs, and soap. A lot of people may feel more comfortable when you say, okay, well, tea, cooking oil, eggs, and soap, and tell me in 5 minutes, and then have to remember these four items. But it's so simple. But you do the mocha, you do the MMSE, they're all okay. You may gonna do a neuropsych test. Remember, the neuropsych test in for patient screening positive for MCI is mainly related to if you're not sure that the level of the MCI is related to underlying depression, anxiety, or you're really not sure about your level of memory loss for a screening test, and you want to have something else. Remember, it's not used in isolation because the main things about that is a clinical judgment. Not every single person with MCI, you should have the neuropsych evaluation in your hand in order to diagnose. Remember that. But it's a very good way. They do the clinical dementia rating CDR, global deterioration scale GDS, and it's useful for staging, but not diagnostic for adjoint tools that you have. And then you may sometimes you ask to follow up as annually. I really like to have the neuropsych test on site. But I'm not saying that for every single person, you need to have neuropsych in order to make a diagnosis. For neuroimaging technique, MRI, PET scan, they can be valuable information because you just look at the brain structure or biomarkers research, for example, in their potential in early detections. For example, we have amyloid or we have amyloid plaque. We haven't researched the tau as well, but technically it's something that you may going to use. The main using the MRI is not a diagnostic that. We're just mainly ruling out other issues. Like, for example, if there's any, first we look at the pattern of atrophy. That's really good. And sometime, and I just want to tell you and one advice, always write the order MRI memory protocol. Please do not write MRI brain without IV contrast because when you write memory protocol, your radiologist will do a different section and will measure for you the amount of atrophy and also looking at hippocampal area. And that's a little bit more focused on vascular. This is why the best thing is going to memory protocol. And again, if there's any hydrocephalus, hematoma, stroke, anything like that, you're looking at that. You're looking at neurodegenerative changes. Like, for example, if you look at the medial temporal lobe atrophy, which is mainly hippocampal area, suggestive of Alzheimer's disease. If you see global atrophy or frontal, it's mainly frontotemporal dementia. If you see parietal or occipital, which is mainly toward Lewy body. And excess vascular burden, you can see, and that's really going to be the part I really like. Many of us, we completely forget about it. I truly love this part because it tells you exactly the white matter, which is mainly related to blood perfusion. If you have vascular risk, high blood pressure, sleep apnea, or any other things, so you really can see that. You can do PET CT MRI, positive, the PET CT you can do any of them. But technically, if you have neurodegenerative MCI from other causes, you can do amyloid plaque PET MRI, PET CT scan, I'm sorry. And you can also look at the overall FDG absorption to look at the hypometabolisms in, for example, frontal lobe or other dementia. Not something that you needed, but you can use it as well. As I said, you have FDG, PET scan, amyloid PET scan, tau PET scan. Again, support early diagnosis for Alzheimer's disease if you have amnesic MCI, improve the diagnostic confidence and aid in prognosis. For example, if you have amyloid positive MCI, it's a high risk of dementia. Not necessarily they have a dementia, but is high risk. And it could be good for guiding treatment and counseling as well. Symptoms of the diagnosis, summary of the diagnosis, as I said, clinical judgment, clinical judgment, clinical judgment, and that's very, very important. And then you have MCI due to Alzheimer's disease that you look at the core clinical feature, cognitive pattern, objective impairment, and preserve independent daily activity and non-demented. And if there's other cause, you look at the traumatic, vascular, and other time, and that's good. I'm going to go quickly on treating. The first thing is going to be identify the reversible because many of the condition it can be related to reversible and it's something that you can prevent. It's going to be important. Why are that? Medications, 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 a lot of anticholinergic medication. For example, you give the medication for bladder incontinence or any other thing, cognitive impairment, sedative medication, a sleeping medication. This is the time, this is the moment that you are as a clinician can ask the patient to stop. Depression and anxiety is the for sleep disorder, send them for a sleep apnea, encourage them to use the positive airway pressure. If there's a vitamin deficiency, especially vitamin B12 and folate, if there's a thyroid disorder, this is the time. If there is a substance and alcohol use, especially this is your time to do the counseling. Alcohol, alcohol, alcohol. It's so important to understand that alcohol has no benefit for memory. And if many of the people think about drinking a glass of wine, it can help. It used to, we would think about resveratrol, but not anymore. We know that alcohol may cause the brain damage and cognitive decline. And that's so important that we discuss with the patients. If they cannot cut completely to zero to reduce the amount, that's the time. And especially even the alcohol effects on atherosclerosis and vascular. Infectious and chronic condition. Like, for example, you used to talk about syphilis, which is less seen these days, HIV or liver damage or any other things that you can do. You talk about vascular risk factor, of course, high blood pressure, diabetes, hyperlipidemia, obesity, smoking, alcohol, which we now talk about it, and evidence-based suggestive of diet. I know a lot of people talk about Mediterranean, and Mediterranean diet is good, but it recently hasn't shown that much more as effective that we've taught about that. But in overall, it's a good thing, especially when we talk about exercise, moderate intensity aerobic exercise, at least walking 150 minutes per week, which is like 30 minutes, 5 days a week, and cognitive and social engagement. I think one of the things for primary care physicians, it's a time to discuss about vascular risk modification. It's a really great time that we focus on that to at least help. And then when we talk about lifestyle modification, we talk about healthy diet and regular physical activity and that. We know about BDNF, a brain-derived nutritive factor, which is a very critical role in maintaining the brain health and is support to survival of neurons and enhance the long-term memory. And we know that whenever the BDNF, especially in Alzheimer's disease, is going to go down, it will go, it causing a lot of problem. And we know that BDNF, it comes through the exercise. The best way to boosting BDNF is through the exercise. Engaging in regular aerobic exercise, cycling, or anything like that, walking, because especially stretching and weight lifting exercise can maximize the BDNF. And this is something you also, even as a primary care physician, can discuss with your patients about that. Medications and the treatments for that. Let me go faster. Cholinesterase inhibitor, as we talk about it. Some trials found modest cognitive benefit, but others shows no significant long-term benefit. As I said, there is a challenge about the really choline deficiency in MCI. That's why it's not routinely recommended. Although I see a lot of people, they give donepezil to people with MCI, amnesic. I'm not saying it's wrong, but it's really not effective. And remember, the cholinesterase inhibitor can have a lot of side effects as well, especially bradycardia, fainting, and even the GI side effect. This is why it just to really evaluate the risk and benefit. Um, there is some evidence talk about intranasal insulin. It's ongoing. It's really not. It's something that is. Some people are using it. I've never personally used that. And we're talking about possibly some insulin insensitivity happen to the brain, and the nasal spray, especially for the people at ApoE4, it's been become some subject that they're doing research. Stay tuned. You may gonna hear more in the future that some people like it because it doesn't cause hypoglycemia. And as you know, as of 2021, we have amyloid monoclonal antibody, and especially as of 2023, we have approval for the two medication of donanemab and lecanemab in United States. Aducanumab also got FDA approval as well, but is not in the market and mainly on the research, which is a target the amyloid plaque, reduce the amyloid accumulation in the brain, and and again, it's just a targeted therapy. It bind to amyloid and help to clean the amyloid. And as you know, one of the major things that it's been concerned about amyloid related imaging abnormality, we call ARIA H and E, either swelling or bleeding. I personally, for many patients that I started the treatment, I only have one amyloid ARIA H. I'm sorry, ARIA E. I had a one swelling case, which is asymptomatic, and we decided to stop the treatment for 2 to 4 months, and we did MRI again, and it was good. But again, it's cost, and Medicare has approved that. But I will say for people that really on the mild stage, it's a possibility that it may slow the progress. Again, the lecanemab, what we see in the trial that we had, that it's I'm just saying the difference between placebo versus the group when you look at the CDR rating, it's about 30% slower decline in 18 months, or 5 months less worsening over 18 months. And again, when they continue the treatment, they see the benefit continue for 24 months. And now this medication even approved to continue beyond of the 18 months. As you know, even the home injection now is available after 18 months that the people can do once a week injection and continue that. I personally say for the patients that I've been trying for 2 years, it has been positive in many of the patients, I will say, especially if they are less tau burden. If they're very high tau burden, it's going to be a little bit different. Donanemab is another one. It's a good one. It's a once a month show, again, a slowness on the functional and cognitive decline. Kind of really similar to lecanemab and the Trailblazer Alzheimer 2, which is a 76 weeks trial. When we look at the donanemab versus placebo, we see that around donanemab, a slow decline by 25 to 40%. And that has been positive overall. The support, it's so important from family, friends, and support group is very essential for MCI. I think coping strategy is one of the major things to help manage of daily challenges, improve emotional well-being. I just say as a physician, it is so important that we play as a role of supporter because the patient's family have billions of questions and a lot of frustration that they need to be aware, and we can actually help through the other also the resources to help with them. Again, in conclusion, I will say mild cognitive impairment is a condition by noticeable cognitive decline that is greater than expected for an individual with age. We have normal aging, which is a gradual decline, but does not significantly impact the daily function or quality of life. Again, diagnosis and the management, accurate diagnosis of MCI versus normal aging is extremely essential for effective management and care strategy because you may have some suggestion, you may able to identify risk, you may even have the discussion about novel therapy for even amyloid monoclonal antibody. And again, awareness of support, it's so important because they need to be aware of symptoms, treatment option, and that really can help for individual experience on that. And I gonna close this here, and it's my email as well here. If you have any questions, I'm gonna stop sharing, and I will see if there's any questions in the QA. But thank you so much for listening to me today.
Well, there is not any questions, which doesn't surprise me because you answered every question that I had. But to the audience, please keep this logged in and keep a copy of this webinar and stay tuned for part two. And I will also encourage you when you receive an email that has the webinar link to it, respond to that email and ask any questions that you may have for part two. And we will address those questions in just about a month. And the parking that you showed, the example, I don't think I have MCI, but sometimes I'm like, oh dear, I got to repark. So I thought it was a phenomenal presentation, and it was so filled with so much information that I think is so critical. And I'm so glad that you brought up the support of the family, the support of the care providers, because when you have MCI or when you're diagnosed with some type of brain difference or disease, it's the family that really suffers. And it's the family that provides the support. So please take the
Sus-
advice and direct your people, your patients and their friends to get some good support groups. I think it's really important.
Thank
Susan,
you,
we do
Zia.
have two attendees that have raised their hand. Would you like them to share their question via the Q&A, or would you like them to share?
That would be great because I guess I can. Hello?
They've raised their hands to be brought off of mute. Would you like me to allow them off of
Oh,
mute, or would you
sure.
like them?
Sure.
Okay.
Absolutely. Yes. Go ahead. Yes. Hi, Julia. You're gonna, there you go. You're unmuted. You can go ahead and ask your question to Dr.
I
Ayati.
was just typing in my question. I actually used to work at a Kensington, and so this my question is a little bit broader, and it's actually about support. So I am a licensed clinical psychologist, and we were going into the facility and providing both therapeutic services, but also cognitive services. So we'd be like playing games, reading, doing memory activities, and other things like that. I was wondering if there was space maybe on this platform to maybe talk a little bit about those services, or to I don't know how that could be helpful during this discussion, or maybe just to the Kensington in general. But thoughts on adding therapy and cognitive support to the clients, maybe in facilities.
I'll start and Dr. Ayati can finish, but I would be very encouraged. I think I can speak for the entire Kensington community that we are always looking for different support mechanisms or people for our residents and the families of residents in our community. And I would encourage you to either reply to that email that we're going to send you with your thoughts, and then we'll make sure that the right people receive that. And we can certainly talk about sharing your support services in part two for sure, because I think that I know that Dr. Ayati works with someone similar to what your profession is. Dr. Ayati?
Yes, of course. No, thank you, Julia, for brought up. I just want to say, scientifically, as we discuss about a part of the I mean, majority part of the treatment actually for people with MCI, it's really going to focus on cognitive retraining and helping to brain to get it stimulated. And as you know, the many of older adult people, they are if especially if they're living at home, they are just turn on the TV in the morning and just watching in front of TV. There's really no brain stimulation. You don't get any brain stimulation from TV. Just hearing all the sad news and everything, and just make you more distressed and depressed. But then but with the activities, as you said, Julia, it's something that big missing in our older adult population, especially the lifestyle we have in modern society, especially United States, because people are going to retire in the loneliness of their home. And that's one of the biggest challenge we have compared to traditional societies, which they have more multi-generations. People are all living together and they have more interaction, social interaction with each other. In this country, we live in the houses, and the minute that we don't work, we just see the walls and the TV. That's all. And when it comes to even facility, the importance of the activities to help them with brain stimulations, something is positive, not just putting all the older people in the facility in front of the TV and just turn on the TV, but rather than having one-on-one interactions and to not at the same time to help them to, which we talk about, many of the symptoms is mood and behavioral symptoms. It really reduced their anxiety and depression. No, thank you so much for bringing it up. I will say that it's extremely essential and important. Unfortunately, we're so behind of the standard of providing more of the services for older adult population in the United States. Hopefully, we will see more. Well, we have to see more because in the 2030, we have a huge number of people 85 years older will be just in, I mean, I would say in California. I'm not talking about the rest of the country in Northern America. We have a tsunami of 85 years older after 2030.
Yeah.
You're in the right business, Julia.
Actually, I was at the Kensington in Sierra Madre, but now I'm over in Redondo Beach where my practice is. I'd like to say a couple of things though. I have found the greatest need is when people are first leaving their home and transitioning into the facility, because that's just a huge life transition.
True.
And then also people that are dealing with the chronic illness that really plays on the anxiety and the depression. And then, like you said, the isolation. What I really loved about the Kensington community is how many activities they do have. But when you get to go there and spend one-on-one time with somebody and build that relationship, that is just so much more giving and therapeutic. And you can see it change the mood and have a really big, strong positive effect when somebody like walks in the door and you are their visitor to see them. And that is just a really great thing. Then also the cognition, getting them to read regularly has been huge, because if you don't use it, you lose it. And reading is just something that everyone can benefit long term, like, and in life. And so we also take Medicare. And so I can get services to people for free, both the cognitive services and the emotional anxiety, depression services.
I think that's wonderful, and give my best to Robert, Nikki, and Tiffany and the whole team there. Thank you.
Yeah, they're great. We go there at least once or twice a week to see one or two clients in their facility. So just to like spread that love, right, is where I'm at right now.
Thank you. Dr. Ayati, John asked a question. Can a 100-year-old have a normal aging brain, and what does that look like?
Yeah, that's a great question. Yes, of course, you can be 100 years old and you can be absolutely have a normal aging process if you do not have any underlying pathological disease. Um, the rule of thumb is it's if you turn 85, if two people is in the room and they're both above 85, one of them already has dementia, and the other one, if you do autopsy or biopsy of the brain, you see the pathology of the Alzheimer's disease progress. That's the things about aging. But however, we have many people in all around the world that they are above 90 and they do not have any neurodegenerative disease. They just have normal aging. As I said, you can have a slower processing speed, means that you cannot do multitasking. You can have some problems mobility by that, but you're still independent in your thinking and instrumental active daily. Means medications, you can remember that. You can able to pay the bills. You can able to do many other tasks. If you have a good vision, if you have a good knees, you even can drive at age of 100 years old. If you do not have disease pathology. But in general, what we see in general population, um, after age of 85, the risk of the neurodegenerative disease is extremely high. That's why it's very likely somebody at the age of 100 can have some degree of neurodegenerative disease. But yeah, we see, I actually personally had a patient, 100 years old, Asian population, that brain was so sharp and functioning very well. The problem was the knee and hip was not cooperating anymore. The brain was
It's
okay.
always something. It's either your head or your
Yeah.
head or your heart or your body that's gonna
Yeah,
out.
exactly.
And Nadia had a question if you're aware of the Traveler study and does it work on mixed dementia, Alzheimer's, and Lewy body?
I'm sorry, what that?
Are you aware of the Traveler study and does it work on mixed dementia, Alzheimer's disease, and Lewy body disease?
No, I'm not familiar with Travelers study. I don't, if you can just tell me a little bit, maybe I just know the study, but don't know exactly the name of Travelers study.
I'll tell you what, Nadia, we will research that and we will talk about that in
Yeah.
March. And we can also talk about the Alzheimer's study, the pointer results, and all that stuff. Thank
But
you,
thank you.
everybody, for joining us. And thank you especially to Kensington and to Dr. Ayati. We're so lucky that you are a medical director. Thank you.
Oh, you're welcome. Thank you so much for having me.
Have a
Appreciate for
good weekend. I
coordination.
guess it is Thursday. Have a good weekend,
And
everyone.
bye bye.
Thank you.